From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to our listeners around the world. You are listening to JAMA Surgery Author Interviews. Thanks for joining us. I am your host, Dr. Amalia Cochran. Our topic today is Familiarity of the Surgeon-Anesthesiologist Dyad and the association with major morbidity following high-risk elective surgery. And I'm speaking today with one of the authors of this study, Dr. Julie Hallet, who is an associate professor in the Department of Surgery at the University of Toronto in Toronto, Canada. Welcome, Dr. Hallet.
Thank you so much for the invitation and having me on the podcast.
I am going to start with me being a curious person, and I am always eager to learn how an investigator got involved with a question, and particularly something like this with a strong tie to our clinical activities as surgeons. I also know that this is an area in which you have quite a bit of related prior work. Can you tell me how you got interested in this specific question of surgeon-anesthesiologist familiarity and postoperative outcomes?
I think for me, like you said, it ties really close to our clinical practice. So for me, it really was rooted into my day-to-day practice as a surgeon. So I practice HPB, surgical oncology. It started by not understanding why it is that every day I show up to the OR, I might have a different anesthesiologist. So for every single day that I operate in a year, I could be working with a different anesthesiologist. We have about 50 of them in the department here. So that's a possibility. And in my mind, it just started by saying, well, in HPB surgery, at least in Canada, we are regionalized. So we can only practice this type of surgery if we meet certain volume requirements over the year and specific training. And my initial question had been, well, isn't it the same for anesthesia? Why is it's only for surgeons? So I started by just studying what happens with the volume of anesthesiologists, specifically for liver and pancreas surgery. And then from that, the next question happened, okay, well, if anesthesiologists do a higher volume of liver and pancreas surgery, patients have better outcomes. There's an association with better outcomes. Now, does it matter who are the surgeon and the anesthesiologist in the room? What I also notice, it's not only their expertise, it's how well I work with them, how well the entire team works together. The one thing I could measure is how often are the anesthesiologist and the surgeon working together. I think it's also important that we work with consistent teams with regards to nursing, anesthesia assistants, perfusionists and other specialties. But the one thing I could measure in my data sets was anesthesiologists and surgeons. And so I started by looking at this question in HPB surgery because that's what I do. And those were the data I had. We published that a number of years ago where we showed that if we work more often with the same anesthesiologist for hepatectomy and pancreatectomy, there's an association of better outcome for a patient. Right after that, I was getting a lot of text messages and emails and questions from people in other specialties saying, what about my specialty? I want to know what happens for us too, because I think it's really important and we need to show that in other fields. And so that's why we created this study that looks at high-risk operations across different fields.
I will admit that I share your bias for benefits to stable teams just because it does seem to flatten the structure. And there's so much organizational psychology work that shows us that those flattened structures are better for dialogue within teams.
The answer I often get when I show those results is people coming to me and say, yeah, it just makes sense, right? It's very intuitive. Why did you need to do that? And the answer is, it does make sense. I share the exact bias and rationale that you just put forth. But sometimes if you don't have the data to back it up, it's impossible to go to your OR executive or to the hospital or to the schedulers to be able to change work organization and change systems so that you can leverage these things. When there's data, it's much more difficult to not pay attention to it.
I want to talk for a minute about the statistical portion of what you all did, and particularly the fact that you used multiple state and provincial databases for this study. Were there any challenges in both using and linking all of those databases that were involved?
Yeah, so we used health administrative data sets that are in Ontario. Ontario is a population of about 14 million people in Canada. And because of the public healthcare system, we're lucky to have every healthcare interaction recorded within those data sets. So everybody in Ontario can be linked in those data sets using something called an IKN, which is essentially an encrypted number. So we can link data sets from healthcare, from the census, socioeconomic status, and we have different indicators. So I didn't have to link those data sets myself or go through that exercise because it is already done within that institute. Some of the challenges, however, with using health administrative data were that we don't have exactly the data we're looking for. If you're designing a prospective study, you're able to determine exactly what you need and collect exactly the data you need with a measure that you want to have. We don't really have that, and it's easy to misuse these data sets. So I think when health services research and large data sets are very helpful, extremely powerful, but you have to respect the data a lot, know the ins and outs of all of it, what it can do, but also what it cannot do. So there are certain things that we could not assess that we wish we could have, but we decided not to because the assumptions would have been too wide in our data.
I wanted to ask a question specifically about the directed acrylic graph that appears in the manuscript, because this was something that was totally new to me. I'd never seen it before, but it's really quite brilliant in how parsimonious it is for presenting your findings. Can you please talk a little bit with me and help me learn more about what is a directed acrylic graft and how and why should one be developed?
My personal bias is it should be included in any manuscript that looks at adjustment. So, we have what I call a main effect model where we have an exposure. This was the number of times anesthesiologists and surgeons work together and an outcome of major morbidity. And we know that there's confounding in that. So we want to adjust the association. And so anytime we do that, we have to pick the variables for adjustment. In our data sets, because we have so many patients and so many events, we could essentially adjust for as many variables as we'd like. That we have the statistical power to do so. But it's not necessarily right to adjust for anything and everything. So what those directed acyclic graphs do is they help identify confounders and mediators to know what needs to be adjusted for and what should be left outside of the model. And what it does, it represents confounders and mediators in a visual way that will look at the assumptions of the causal relationships between the variables. So the confounders are the variables that are influencing both the exposure and the outcome, and are not on what we call the causal pathway, and we should adjust for those variables. And then the mediators will be those variables that are caused by the exposure themselves, and that way end up causing the outcome. So they're not independently associated with exposure and outcome. So we say that they lie on a causal pathway. And if you adjust for them, you might actually over-adjust and miss the effect between the exposure and the outcome because you've adjusted for the reason why the exposure affects the outcome. There's this visual way to represent that, and that helps identify what to adjust for the confounders and what to leave out of the model or maybe explore in different way the mediators. And what it does, it helps prevent, number one, omitting important variables to adjust for, and number two, avoid over-adjustment bias, in that you've adjusted so much that you're masking the association you're actually trying to identify. And so that's what we did here. There's things that we did not adjust for. For example, the type of cancer or the surgical approach we did not think was associated with the number of times anesthesiologists and surgeons work together. Because of that, we did not adjust for it because it wasn't associated with exposure and outcome. For example, the hospital setting, whether academic or community hospital, we adjusted for because that influences how scheduling is made and so how often anesthesiologist and surgeon will work together. And it also may influence the outcome of the patient depending on the structures of care. So that's how we did that. And we even present it in the supplement for those that are interested in opening the supplementary files.
To give our readers a specific breadcrumb to get to it, it's e-figure 1 in the supplement. And I think it's well worth exploring because, again, this was a new to me concept, but it was one that I was really excited by when I saw it. Why did you think that it was important to discuss the importance of both familiarity and optimization of processes when you got into your discussion for the manuscript?
The short answer is because familiarity cannot be replicated by processes, protocols, or pathways. And again, having presented on this topic several times, I get that answer all the time, and often by people in leadership. Like, okay, so what is it that makes those familiar dyads work better together so that we can replicate it? My answer to that is always you cannot put familiarity in a jar and just give it to everybody when we enter the operating room to make things work better. There is something about two people working together more often, whereby we create what we talk about in the discussion of the paper, transactive memory systems. And that creates cohesion, collaboration, greater likelihood of accepting help from others or offering help to others, an understanding of what work needs to be done. And all of that leads to creating potentially better outcomes for patients. And we cannot replicate that. If anybody is interested, there's a very great podcast by Adam Grant. I love listening to his business psychology podcasts. But in one of them, he talks about how you build teams and how team design is even more important than team dynamics. And he uses the example of the miracle on ice in ice hockey for that, and refers a lot to work by a professor in social and organizational psychology. I think that was his field at Harvard, Richard Hackman. And what he showed in his work is that trust between teams emerges when people work well together. There's no other way around it. In other words, you can put me and my team to as many thrust exercises and team building activities as you want. If we don't work together well, if we don't build trust with each other by working together often, it's not going to lead to any benefits. And so I think processes and pathways and protocols are important. They're a critical pillar of quality and safety in surgical care, but they do not make up for unstable teams. And to me, that was a very important message to get across.
So here is my question, and that is, as a patient, should I ask how often my surgeon and my anesthesiologist work together? Is that something that I should be concerned about?
Why not? It's the same question about volume. Should patients ask what's the experience of their surgeon with a particular type of surgery? I think that's become much more common and frequent nowadays because we know more about the volume outcome relationships and it's gotten into the lay media and so on. So people know to ask about that. We may have to ask, maybe not necessarily the number of times an anesthesiologist and surgeon have worked together, but how is your operating room team organized? Like, what's the experience of my surgeons? What's the experience of my anesthesiologist? How are you all working together? I think that's a fair question. Maybe a few decades ago, people would not have asked how many pancreaticoduodenectomy I had done, but now they're asking, and I think that's a fair question. I also feel to some extent it's very important to do it because lots of change originates because patients are asking. And it's all about the patients. It is their care, it is their outcomes. And if they're asking, I feel there's much more likelihood that things are going to change than if just you and I are trying to push from inside.
My closing question for you today is, what is next in this space for you? I have a bias on what I would love to see your group work on because I am a burn surgeon. And so I work in a fairly acute type setting, definitely less elective setting. But I'm curious what you're looking at next in terms of expanding on this work.
Yeah, that's $1 million question. So two things. To me, first, we can expand to other fields. So we focus on elective surgery a lot because that's where there's the most opportunity for applicability because we can schedule things, right? There's like a certain planning associated with elective surgery where we can make changes in work organization and scheduling. For emergency surgery, it's much more difficult, but we're looking at ways to do this kind of work also in the acute care setting. We have a big group of trauma and acute care surgeons where I work at Sunnybrook. So we're seeing how that could potentially apply. And then the second thing, at the very beginning, we talked about how this comes from a day-to-day experience in clinical practice. For me, research work has no impact until it ends in clinical practice. Like, I'm very happy that this is published in JAMA Surgery, but until it hits the clinical world, our job hasn't been done. And there's lots of barriers to that right now. Like, there's resistance to any change. For years, we've received the comments about all the reasons why this is great, but it's not possible, and trying to address that. Part of that is we're running right now qualitative interviews with anesthesiologists in particular to understand what's their perception about potentially specialized team or leveraging more familiar dyads, because that's a different work organization for them. How do they see it What are the barriers for them? What are the issues that they foresee? So that as we're building those care models, we can address these things and potentially look at unintended consequences, right? Some of the information we got from those interviews, we're now trying to address in population data. So for instance, anesthesiologists are worried that if they have a more specialized practice, if they work with the same surgeon who does hepatobiliary or vascular more often, they're going to lose their expertise in other types of surgeries that they need to be doing to cover call, for example. And so we're trying to address that. Is increasing the number of cases in one area decreases the number of cases in another area and influences the outcome of patients operated by that anesthesiologist in another area. So that's what we're doing right now. So investigating those unintended consequences so that at the end of the day, we can have more informed and comprehensive discussions about how to build those models of care and hopefully influence change.
That is all incredibly exciting work. Dr. Hallet, thank you so much for your time today. I've really enjoyed having the opportunity to sit down and discuss your work with you some more.
Thank you again for the invitation and the visibility provided to this work by the JAMA network. It's very appreciated.
I am Dr. Amalia Cochran, the web and social media editor for JAMA Surgery, and I've been speaking with Dr. Julie Hallet from the University of Toronto. This episode was produced by Shelley Steffens at the JAMA network. You can find a link to the manuscript in today's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.